My name's Kate and I'm a research fellow at the University of Southampton. In our lab, we're interested in investigating the biology of hearing loss and how our immune system interacts with cochlear implants, which are the hearing devices for people with severe to profound hearing loss, and then how the interaction between the body and the implant might affect how well someone does with their cochlear implant. So our research group works closely with the Auditory Implant Service, which is on the university campus. And this is a service which is for people from the south of England and the Channel Islands, for people with severe to profound hearing loss who may require an auditory implant. So we work closely with the clinic. So for this talk, I'm just going to tell you about our work where we've been investigating the cellular response or the tissue response to cochlear implants. So hearing is a sense that we most rely on to communicate and engage with others. So hearing is the perception of sound waves traveling through the outer and middle ear to the inner part of the ear, which is called the cochlea. In the cochlea, these sound vibrations are converted to neural signals or electronic signals through the action of specialized hair cells, which then stimulate the neuron in the cochlea to send the information to the brain. So sound waves are collected and funneled into the ear canal by the pinna, and the sound vibrations move along the ear canal to reach the tympanic membrane, causing this to vibrate. This results in movement of the three ossicles, which form the middle ear, ending with movement of the, if I just get the laser pointer, ending with movement of the stapes, which is in contact with a window on the cochlea, causing the window to vibrate. So here there is a transfer of vibrational waves into fluid-filled vibrations within the cochlea. So then the fluid-filled vibrations in the cochlea are converted to electrical signals through these specialized sensory cells. And the electrical signals stimulate neurons in the cochlea or the hearing nerve, which sends information to the brain to be perceived as sound. So damage to any parts of these systems can lead to hearing loss. So currently there are 12 million people with hearing loss living in the UK, and this number is estimated to increase to 15.6 million people by 2035. So that'll be affecting around 1 in 5 of us. So hearing loss is one of the highest risk factors for dementia, but importantly, it's a modifiable risk factor. So hearing tests are encouraged for people over the age of 55 or who are at higher risk of hearing loss. And the use of hearing aids and or cochlear implants are recommended for those with hearing loss. So people who are severely to profoundly deaf, who do not get any benefit from hearing aids, may be suitable for a cochlear implant. So cochlear implants are the most successful neuroprosthesis, and their role is to replace the function of damaged sensory cells in the cochlea by directly stimulating neurons of the hearing nerve to send the information to the brain to be perceived as sound. So cochlear implants are this device here, which you can see in the photograph, and they're suitable for people from all ages, from under the age of 1 to over the age of 100. And they give people the ability to enjoy conversation, music, education, and employment. So cochlear implants consist of 2 main components. You've got the externally worn sound processor, which looks a bit like a hearing aid, which is connected to the headpiece. And then you've got the internal component, which is the implant receiver stimulator. And this is connected to the electrode array, which is inserted into the inner ear. So the sound processor captures the sound information and transforms it into a digital signal, which is then transferred to the implant receiver stimulator. And here it's converted to an electronic signal. And the electronic signal is then sent to the electrodes within the cochlea. And these release current, which stimulate the nerves within the cochlea to then send this information to the brain to be perceived as sound. So despite the great success of cochlear implants, there is a group of people who do not get optimum benefit. And this is what we're interested in. So in some cases, it seems as that the interaction between the body and the implant, the cellular response, is responsible for underperformance. However, we still don't know a great deal about the cellular response to cochlear implantation. So this diagram here just shows you the tissue or fibrosis that forms around an implant and the different cells that are made up of it. So there's different types of cells indicated in this figure by the different colors and shapes. So what happens in the inner ear following implantation? So the body's immune system responds as part of the normal wound healing process. And this response should resolve. So it's made up of 3 different phases. You've got inflammation, repair, and then resolution. So in the inflammation phase, that's when immune cells come to the wound site and they release signaling molecules as part of a normal inflammatory response. Then you've got the repair phase, which involves formation of blood vessels. So the blood vessels are delivering nutrients and oxygen to the wound site. And also in this phase, you get increased production of collagen, which is forming this fibrosis or the tissue. And then finally is the resolution phase, where you get a decrease in the immune cells and the collagen producing cells, and you get formation of a mature scar tissue. So the process, or this process, the typical wound healing response, is the same as a type of response you get if you fall over and cut yourself. In some people, however, with a cochlear implant, this response does not resolve as it should. And this can lead to chronic inflammation and increased tissue growth or fibrosis around the array. So increased inflammation can cause damage to the cochlea and the nerves which are in the cochlea, which are necessary for the implant to function. So this isn't favorable. And also increased inflammation, as I said, leads to increased amount of tissue. So this figure here shows sort of the normal amount of fibrosis that can form around an electrode array, which is fine and can be beneficial. But the red shows you an increased amount of tissue growth, which is not favorable, and this can lead to higher impedance. And impedance is the resistance with which the electrical current flows from the electrodes into the inner ear tissue. So if there's a higher amount of tissue growth, there's a higher amount of resistance for the current to flow, and this can lead to poor performance and sometimes result in soft failures. So as I mentioned at the start, there's a group of people who don't do as well with their implant, and these are considered poor performers. And in some cases, the poor performers then go on to experience soft failures. So soft failures are adverse events that are not caused by hardware or surgical factors and are therefore likely due to individual characteristics, including the interaction between the body and the implant, the cellular response. So soft failures are a persistent problem, and they do lead to replacement of the implant, which then requires a whole another surgery. So it can be a problem. So a better understanding of what causes poor performance and soft failures and the type of tissue response that happens in these cases may enable us to find ways to reduce the amount of people who are poor performers and therefore increase the benefit people can get from their implant. So we carried out a study where we investigated the cellular response to the implant in someone that was having their implant removed due to a soft failure. So through our collaboration with the Auditory implant service on campus, we became aware of a lady who over a period of just 10 months of implantation was showing different symptoms and clinical indicators of a soft failure. So she had a decrease in hearing performance with the implant over time, and she had fluctuations in impedance. So there was big changes in this resistance of the current to flow, which led to electrodes actually having to be switched off. So then they were no use. And then there was also movement of the array out of the cochlea. So the decision was made that this lady would undergo replacement surgery where the surgeon would remove the current implant and then put a new implant in. So following ethical approval and consent from this lady, we collected the implant and the tissue attached on the day of surgery for analysis. So the aim of this work was to characterize the cellular response of the tissue that formed around an array over the course of 10 months. So this is a photograph of the array after it had been removed, and you can see the tissue that's covering the array. And the tissue was covering at least 4 of the electrode contacts, which you can see here by the black arrows. So we removed the tissue from the array and we processed it for molecular analysis. So we cut the tissue into very thin sections and put them on glass slides So then we could add different stains and markers to the tissue to investigate the structure and composition and to look at what different cells were expressed. So this is just a photograph of one of the tissue sections that had been stained with just a general histological stain that gave us an idea about the different distribution of the cells. So as I said, we used histological stains. So we used different chemicals to add to the tissue to give us an indication of what cells were there and what the tissue looked like. And we also use a technique that identifies specific cells using antibodies, so immunohistochemistry. And looking at the tissue, we found evidence of active inflammation and ongoing tissue repair. So we found evidence of different immune cells across the tissue, suggestive of increased inflammation. We also found signaling molecules which were released by the macrophages as part of the inflammatory response. And we also found evidence that there was ongoing tissue repair. So there was an increase in the number of cells. So there was proliferating cells, and also there was new blood vessels forming. So this type of response with active inflammation and sort of ongoing tissue repair is not what we'd expect to see 10 months following implantation. So if you think about a wound site somewhere else in the body, we would normally expect the wound to heal and a scar to form much before 10 months following the injury. So in this study, we took a systematic approach to use specific markers to tell us about the active state of the tissue in relation to the typical wound healing response. So in this case, we're hypothesizing that there was increased inflammation and ongoing tissue repair, and that the response didn't actually reach the remodeling stage where the mature scar tissue forms. And we think that this aberrant wound healing response contributed or caused the decrease in hearing performance and led to the soft failure in this case. So from carrying out this initial study, there were several key questions which we wanted to address. So in order to address these questions, we've designed a larger human tissue analysis study where our aim is to characterize the cellular response to the implant and factors that influence this response in multiple people who are undergoing replacement surgery. So this is just the design of the study. So if someone is identified as requiring replacement surgery, we will aim to recruit this person. And then in the lead up to their surgery, we'll ask them to complete a hearing and a health questionnaire just to gather some more information about the participant. And then on the day of surgery, the surgeon will remove their current implant and replace with a new one. And we will collect the array and any tissue that's formed around it for analysis using molecular techniques. And alongside analysing the cellular response, we'll also be collecting hearing and health data about the participant, as we know multiple factors can influence cochlear implant performance, and that may therefore influence the tissue response. So the hearing data that we'll collect, we'll look at the speech recognition score. So this is just a normal hearing test that happens routinely in the clinic. So we'll look at the data for that, and also this resistance of the current to flow, so the impedance. And we'll also look at previous medical history for the participant to see if they've got any comorbidities with an inflammatory component, which might link to the type of response that we've measured. So characterizing the cellular response to cochlear implantation in living people with a cochlear implant hasn't been done before. So all of the studies that have been carried out previously have been in post-mortem tissue, so where the tissue is collected at the end of life. And a disadvantage of those studies is that there's often limited clinical and health data available. So a benefit of this study is, alongside collecting and characterizing the cellular response, we'll also be looking at the health data and clinical data for the participant, which may give us an indication of the different factors that are influencing the type of response. Another benefit of this study is that we will be using the more specific technique, immunohistochemistry. So most of the studies that have been done previously only used histological stains. So it was a less specific technique. So we'll be using a more specific technique in a larger number of cases. And finally, we'll be able to look at clinical data following reimplantation to see how well someone does with their new implant. And this may inform reimplantation protocol. So this work should enable us to identify biomarkers associated with poor performance and failures in people with a cochlear implant, and improve outcomes by identifying factors that affect the tissue response, and therefore find ways to alter or intervene with this tissue response. And this is the research team involved in this work. So yeah, thanks to all those people involved, and also the future and the past study participants, and also, yeah, I work with the Auditory Implant Centre. So thank you for listening.